Nausea and vomiting is another incredibly common symptom that we see in palliative care, and is especially common in seriously ill patients. So there's been estimates that it's around 40% of patients in their last 6 weeks of life. So nearing the end of life, it's very, very common. Certainly cancer, especially GI cancers, but all kinds of cancer can cause it. And then, of course, heart failure, HIV, AIDS. And then it often can be a part of a symptom cluster. And it absolutely can cause other forms of suffering and distress, like patients' worries about, will they be able to get enough food? Will they get dehydrated? What does this mean for their disease? And also there's a lot of fear of loss of control and dignity that comes with nausea and vomiting. So this is something that causes a lot of suffering in our patients. Also, very medically speaking, it can have a lot of complications that we have to keep in mind, like electrolyte imbalances, malnutrition, aspiration risks, and some of these other things that you can see here. And then ultimately it's the suffering, the refractory suffering that can be left over, can be immense. So again, and we'll move through this a little bit more quickly just so we can get to some of the management principles for nausea and vomiting. So nausea, again, it's subjective. So there's a lot of different receptors that we're going to talk about in a moment that can potentially be a culprit, but ultimately the only way to know if a patient is feeling nauseous is to ask them. And it's caused by noxious stimulation of one of 4 different sites. And we're going to show this anatomically in a moment. So the gastrointestinal tract, the vestibular system, the chemoreceptor trigger zone, and then also higher centers in the central nervous system. Did I see a hand in the back, or were you just stretching?
Stretching.
Okay, no problem. Stretching is good. So vomiting, often associated with nausea, but not always. So vomiting almost always is related to nausea, but not all nausea always results in vomiting. So is the forceful expulsion of gastrointestinal contents. And what ultimately occurs is the activation of the vomiting center, which then sends parasympathetic and motor afferent activity to the esophagus, to the throat, to other muscles to actually cause the reverse peristalsis and leads to the vomiting. So these are the points, and this will ultimately be important because we have to think about where these different receptors are, is how we decide how we're going to actually treat nausea in our patients. So this is where these various places are. So you can see at the very bottom, so the GI system, so inflammation in the GI system. Then we know more in the inner ear and parts of the brain are the vestibular apparatus, which can more be related to dizziness. If somebody were to go on a roller coaster or they were to spin around in a circle a bunch of times and then get nauseous, that's more related to the vestibular apparatus. And then the chemoreceptor trigger zone. So this is where we think more of toxins or other chemicals that can be in the blood that the brain picks up on and then ultimately causes the body to feel nauseous. And then finally, more central components in the cortex, which can be related to anxiety, fear, emotional responses. And all of this together can then send communication to the vomiting center and actually result in the body vomiting. So I highlight all of these, not just to review what we learned in medical school, but the next thing is to think what affects these and then which receptors are involved. So like we were just mentioning, stress can impact the cortex, drugs, metabolic upset, or increased intracranial pressure. Again, think more toxins in the chemoreceptor trigger zone. And then the vestibular apparatus, like we were saying, more motion. And then finally, GI tract inflammation. So now this next addition to the slide is the piece that I really want you to try and remember. So the question is, which receptors are in these particular areas? Because then that will help us decide which medications we're going to use, because all of our nausea medications target particular or groups of receptors. So stress, we think about GABA. For the chemoreceptor trigger zone, so again, thinking about toxins, we think about dopamine. So dopaminergic reactions or receptors is really what can cause the chemoreceptor trigger zone to become activated. After that, there's a little bit also of serotonin. So when we say 5-HT, we're referring to serotonin. When we think about the vestibular apparatus, that's more histaminic or histamine. So antihistamines will be more helpful with that. And then finally, in the GI tract inflammation, mainly we're talking about serotonin then, but also a component of dopamine. So we'll clarify this and then talk about the medications. But this slide, I think someone taking a picture. That's more than welcome. You're welcome to take a picture. I really want you to keep in mind these different receptors, and because that will sort of help shape what we're going to use to treat. So the first step in a patient who's feeling nauseous, is to think about what potentially could be causing it. So an easy acronym, there are some longer ones that include a longer list, but I think this is the simplest and most important one, is vomits. So thinking about the letters, and each one stands for different things that can cause nausea. So V is for vestibular, again, more motion, dizziness. O is obstruction, so an obstruction in the bowel. M is motility or dysmotility or poor motility. Could be from an obstruction, but also there's lots of other causes of poor motility. Opioid side effect is a very, very common one. I for infection or infections. This could potentially cause dysmotility and obstructions, but also could cause those toxins to increase or GI inflammation, just sort of how we think about these things. Next is toxins, and then finally stress, more centrally mediated in the cortex. So vomits, VOMITS, is something you can think about when you're trying to come up with why is my patient feeling nauseous.